Hello everyone. Today we will discuss about the Down and Somogyi phenomenon that often happens in patients with diabetes mellitus. So what is it? First of all, there will be fasting hyperglycemia, and it is a frequent clinical problem in patients with diabetes mellitus receiving insulin or oral hypoglycemic agents. Two important and classically described mechanisms responsible for early morning hyperglycemia are the Down phenomenon and the Somogyi phenomenon. Although both present with elevated fasting plasma glucose, their underlying pathophysiology, diagnostic features, and therapeutic implications are fundamentally different. Accurate differentiation is essential to prevent inappropriate escalation of insulin doses and also to avoid a recurrent nocturnal hypoglycemia. The presenting complaint. So, patients with either phenomenon usually present with persistent unexplained high fasting blood glucose level despite apparently adequate treatment compliance. The common features include persistent elevated plasma glucose on self monitoring because it happens in the early morning, discrepancy between good bedtime glucose and high morning glucose, poor, poor overall glycemic control despite adherence to insulin or oral drugs, unexplained rise in HbA1c, and physician detected fasting hyperglycemia during routine follow. The historical clues. So the evening insulin dose will be often inadequate in case of Down phenomenon. It will be often excessive in case of Somogyi phenomenon. Dinner intake will be normal in Down phenomenon, but it will be missed or inadequate in Somogyi phenomenon. Excessive physical activity may be contributory, but it will be excessive in Somogyi phenomenon. Alcohol intake at night is usually absent, but it may be present in Somogyi phenomenon. So the definitions. Dawn phenomenon. It is a spontaneous rise in blood glucose concentration, usually in the morning hours of early morning 3 to 6 a.m. It is not preceded by nocturnal hypoglycemia. It is due to circadian secretion of counter-regulatory hormones and inadequate insulin action that is supposed to compensate, which happens in case of normal individuals. Whereas in case of Somogyi phenomenon, early morning hyperglycemia occurring as a rebound response to antecedent nocturnal hypoglycemia. It is caused by excessive evening insulin or inadequate carbohydrate intake at night. It is also called as post-hypoglycemic hyperglycemia. Coming to the pathophysiology. So there will be a rise in growth hormone, which is the major contributor, following by cortisol, glucagon, or catecholamines. The effects, there will be increased hepatic glycogenolysis, increased gluconeogenesis, and increased insulin resistance. Inadequate compensatory insulin, there will be fasting hyperglycemia. In case of Somogyi phenomenon, excess insulin or missed meals results in nocturnal hypoglycemia. This results in counter-regulatory hormonal surge, which will result in increased hepatic glucose output. This will result in rebound early morning hyperglycemia. Coming to the treatment, the core problem here is insulin deficiency, whereas here the core problem is insulin excess. The goal is to increase the basal insulin. Here the goal is to prevent a hypoglycemic episodes. The basal dose has to be increased here. It has to be decreased here. Timing can be shifted later. It can be shifted earlier. There is no need for any bedtime snack here, but bedtime snack is required here. And insulin pump, we have to increase the basal insulin and we have to reduce the nocturnal basal insulin here. As far as the patient education is concerned, complete education about both the phenomenon is required. Here there is a hormonal surge. Here there will be rebound hypoglycemia. Avoiding late carbohydrates and adding bedtime snack is required in Somogyi phenomenon. And insulin advice: don't skip a basal insulin, and we should not escalate it blindly in Somogyi phenomenon. So there will be night sweats and nightmares in Somogyi phenomenon. So to summarize, it is due to Dawn phenomenon is due to circadian hormonal surge. Somogyi phenomenon is due to rebound hypoglycemia. Nocturnal hypoglycemia is absent in Dawn phenomenon, present in Somogyi phenomenon. The 2 to 3 a.m. glucose is normal or high, but it is low in Somogyi phenomenon. Insulin status is deficient in Dawn phenomenon. We need to increase the insulin, and bedtime snack is not needed. And there is a possibility of benefit by increasing the insulin. Whereas in case of Somogyi phenomenon, insulin status is excess. We need to reduce the insulin status. Bedtime snack is needed, and increasing the insulin dose will result in harmful for patients. I hope you understand from this lecture.